Thank you very much, Joe. And before I started doing ultrasound, laparoscopic ultrasound, I pretty much did routine cholangiography, and that was an excellent talk that you gave. One other thing that I might add is I often tilt the patient head down because of the gravity really will fill the proximal ducts, and that was my routine. And I think since I've started doing ultrasound, I found it a lot quicker, a lot easier. It does have some problems, and I hope to introduce you to ultrasound because you're using ultrasound in other areas. It's fairly readily available now in most ORs. The most expensive part of the equipment is the transducer itself, and they're a bit fragile, and we often have problems with repairs on that. But aside from that, it's really the ideal tool. Let's see. And before I get started, I have nothing to disclose. A few definitions. Most of you are already learning ultrasound. 1 cycle per second is a hertz. A megahertz is 1,000,000 cycles per second. Human sound goes up to 20 megahertz. Ultrasound is greater than 20 megahertz, and kilohertz. And medical ultrasound is 1 to 30 megahertz. One of the things that we know is that the lower the frequency, the better the tissue penetration, but the resolution is not as good. So one of the things I often do is try to use the highest frequency so I can get the best resolution and the best image. Other definitions you need to know: transducer is the tip of the ultrasound probe, whether it's handheld, whether it's at the tip of endoscope or a laparoscope. It contains the piezoelectric crystals which vibrate to create an ultrasound wave. It receives the reflected sounds as well and transforms these into electrical impulses that go to the ultrasound unit, which is simply a high-speed computer that converts these into an image. Real time just means that it happens so fast it looks instantaneous. This is one of our older ultrasound units, and this ultrasound can be taken all over the hospital. You can use it on the floors, you can use it for many other things. They're relatively inexpensive. This is a thing that we really need. You need to have a dedicated laparoscopic probe. I tend to gas sterilize all our probes instead of putting covers over them, so it takes a little while, and if you do one case and try to follow with another case, sometimes equipment can be a problem, so you really want to have several probes. But you have to be very careful because they're easily damaged. This is a typical setup. This is one of the residents doing a laparoscopic cholecystectomy. And with a 5mm scope, I like to use to see the tip of the ultrasound probe through the 5mm scope, and then I put the 10mm ultrasound probe through the umbilical port. You always want to have a nurse that knows how to run the units so they can adjust the contrast, the frequency, the size. You can't do it on your own. And this is just another view with everything set up, looking at the image and knowing where your probe is, which is critical. You have to know exactly how you placed your probe. And I've really kind of come up with 5 steps for screening for common duct stones using laparoscopic ultrasound. And I want you to look at this again. This is the ideal thing. What is it, 17% of the anatomy? So, and most of the time it is variations, and you do see that with ultrasound. The first thing I recommend, step 1, is to inspect the gallbladder. Look at it, also put your probe on top of it. And then the second step is do the trans-hepatic view, go through segment 4B, and use the liver itself as the acoustic window to get to the intra-hepatic biliary tree and the proximal common duct. Then step 3 is the hepato-duodenal ligament approach, where you have the probe directly on top of the hepato-duodenal ligament, and that gives you your best look at the common duct. You slide down over the head of the pancreas to get the intrapancreatic portion, and then a trans-duodenal view so you can look toward the ampulla for distal common duct stones. Now this is, again, step 1, inspect the gallbladder, look at it. This is a normal one, and you can see that there's no thickening of the wall. The lighter reflection is a mucosa, the darker line is a muscularis, and then some of the adventitia. Here's a typical look at a gallbladder with multiple stones. The stones are dense enough that it creates shadows behind them, deflecting the ultrasound waves. This is a thickened gallbladder in acute cholecystitis. This is not a stone, but probably a cholesterol polyp. Given time, it will become a stone, or it could be a true polyp. This is a patient of mine that had a gallbladder cancer with invasion into the liver. So there's a lot of information you can get with the ultrasound. Again, the trans-hepatic view, this is step 2, where we're looking through the acoustic window of segment 4B. We can look at the proximal common duct, the right hepatic artery, portal vein, a lymph node, caudate lobe, vena cava. This is a deep view. You can get a more shallow view. And this is a shallow view, but the probe was placed transversely, and we can see the right duct, left duct. This is the left portal vein and the right portal vein. This is just a diagram showing you what you're looking at through the liver. Then we go to step 3, the Hepato-duodenal ligament longitudinal view, where you're directly on top of the common duct. And sometimes this is a little difficult if the patient's too thin, because you can compress the duct. But here again we see the common duct, the more typical anatomy, the right hepatic artery going behind the common duct, as we saw in that diagram earlier, portal vein, caudate lobe, the vena cava. And as we go down a little further, you can see the cystic duct entering the hepatic duct to form the common duct. And this is a patient who had a 1.6 centimeter common duct. You can measure it with the acoustic calipers and some stones as well as sludge. So this is also step 3, but instead of the longitudinal view, a transverse view. This is sort of the Mickey Mouse view. You have the 2 ears and the face, and this Mickey happens to have a ring. And what we do is we put the transducer in a cross section, and we can see the common hepatic artery, the common duct, the cystic duct, and behind that is a portal vein. If there's any doubt, you can use color Doppler, and it shows that there's no blood flow through this. This is the common duct. But in this particular case, you can see a replaced right hepatic artery. So you really get a lot more anatomy. You get cross-sectional anatomy, longitudinal anatomy. You can see through the organs. So you can get a lot more information with ultrasound than cholangiography. Going through the head of the pancreas, as we go down to the distal common duct, this is where most stones are. And most of the time, the patient's head is up a little bit, so gravity does have them float down. And this patient had a common duct exploration. This is a nice view of that particular stone with a choledocoscopy. And then the final view that we take is try to use the acoustic window of the duodenum, because there's less fat there, and sometimes there's so much fat on the head of the pancreas that it's difficult to see the common duct. And this gives us a better look at the common duct. And don't try to get this kind of a look at an ampulla. I've never been able to reproduce it, but what this tells you is that you can go all the way down into the ampulla, sometimes see masses. But this is a cross-sectional view, common duct, pancreatic duct, the ventral pancreas, which tends to be hypoechoic, dorsal pancreas a little lighter, and the vena cava. So we're really dissecting these organs as we're looking through. This is the big advantage over cholangiography. And we can see a lot of things. This is a patient that has an ampullary tuberculous adenoma with atypia. Here's a patient that has, you can see the common duct and the cystic duct, and an enlarged node, which could be a reactive node or a lymphoma. And we see cysts in the pancreas all the time. And you can evaluate these and get a better idea of the surrounding structures if you see anything fishy. This particular case in the distal common duct, we saw what looked like is this little cholesterol stone, a little adenoma. We did a cholangiogram. You can see a little indentation, but we really didn't see a mass. In this particular case, we did do a choledocoscopy, and those are little papillary fronds that you often see, even at ERCP, when you do a little papillotomy. So that was nothing. But there's a lot you can see with ultrasound that you can't with cholangiography. Advantages: quickly performed, repeatable, no radiation, much less expensive. The biggest expense is the probes and learning how to use it. It's as sensitive as intraoperative cholangiography, more specific than intraoperative cholangiography, and it gives the anatomical information that we discussed. These are old studies. Nobody's doing studies on ultrasound. We showed this a long time ago. You'll rarely find a paper, but the results are all good. It's quicker than cholangiography, depending on your expertise, and they're very similar in sensitivity and specificity. Now, there are disadvantages. Nothing's perfect. The bile duct anomalies are not seen, especially with normal ducts. They don't fill as well. You're not going to see the replaced right hepatic so well. You don't have the ability to see the anatomy you see with cholangiography. Small common ducts, as I mentioned, are hard to see. A thin patient with very little fat, sometimes this can be very difficult to find. The fat will obscure. Here's a pancreas, a very fatty pancreas. You see a nice clear common duct here, but when you get behind the pancreas, you get poor vision because of the fat doesn't transmit things well. This is a non-shadowing stone. This is an artifact. You have to know artifacts. There is a learning curve. Our first 140 cases, our sensitivity was not as good as cholangiography, but after that, our sensitivity and specificity was just as good as cholangiography, and that's our routine. So in conclusion, lap ultrasound is a valuable tool that provides real-time window into intra-abdominal organs for both diagnostic and therapeutic uses. It is as sensitive and more specific than cholangiography. It gives anatomical information of the surrounding structures, but there is a steep learning curve. But as surgeons use ultrasound more and more for other things, I think this is a tool that you really ought to consider using for routine gallbladders. And thank you.